Welcome to the St Emlyn's podcast. I'm Iain Beardsell.
And I'm Simon Carley.
And this is our review of all our blog posts from August and September. Summer seems a long time away. Autumn is here. The leaves are turning. It will soon be winter. Winter in emergency medicine feels like an 11-month game, but the actual season of winter is coming. But Tom, it's great to be recording with you again. Last time we were chatting was at the Basics conference, and it's probably worth just highlighting what we did there, and also to say a big thank you to John Barrett and Holly of Basics for inviting us and making us feel so welcome and facilitating some recordings. But we had a good time and got some good stuff done.
Oh, yeah, it was really good, actually. It's quite a small conference, isn't it? So really quite good family atmosphere to it. And some amazing talks, actually, particularly about pushing the sort of the limits of resuscitation science. So a lot of what we've been talking about on the blog was also talked about at the conference. And this emerging concept, which has actually appeared in the ERC guidelines this week, about this physiology-targeted resuscitation. A lot around that. And I think we are seeing a bit of a paradigm shift. Maybe that's too much of a thing about how we approach high-level resuscitation in particularly in our cardiac arrest and trauma patients.
And we have some great podcasts coming up over the next few weeks. Some really interesting topics, from how to survive being ejected from a plane to the concept of what we decided to call a cognitive halo, those things that are high acuity but lower currents but affect your brain, as opposed to things you have to do. So we talk often about physical halos and learning how to do a lateral canthotomy, but this was chatting with Hutch, member of the St Emlyn's team, about how we cope psychologically with things that can happen and don't happen often. So there's some interesting stuff from that. And you'll already have heard, I hope, Captain Surgeon Ed Barnard's talking about the abdominal aortic junctional tourniquet. So lots to come from there. And while we're talking conferences, the Basics conference will be on next year. Keep an eye out for it. But very excited for Incrementum. That's coming up in April next year. Worth having a look to see if you can get some tickets for that. Simon and I will both be there, along with some big names from the world of emergency medicine. But that's a fab conference, and we talked a lot about it here. I've been chatting to the guys at the Big Sick in Zermatt. I'm sad to say, if you haven't got a ticket, they are sold out. So going to Zermatt in February is no longer a thing, unless you have a ticket already or are aiming to go in 2027. But that's another thing to look forward to. And Tactical Trauma will be back next year. If you fancy a trip to Sweden in November 2026, learning all about tactical medicine. But let's get on to some proper evidence-based medicine and from the content from the blog from August and September. And you started summer with a bang, talking about something that I know is close to your heart and something we've talked about before, which is arterial line placement during cardiac arrest, and how this can actually convert into emergency departments. You mentioned earlier the new Resuscitation Council guidance, and that talks a lot more about physiological guided resuscitation. So I'm sure this will come into being a lot more, and we will be putting more arterial lines in. But this was a paper that you reviewed. Tell us some more about it.
Yeah, so placing of arterial lines for, again, aiming towards this physiological management of things like cardiac arrest is really important because it gives you, of note, the diastolic blood pressure, which is what we're trying to raise above 35 millimeters of mercury to maintain cardiac perfusion. I remember taking a case into one of our local hospitals recently, post-ROS patients, and handing them over to the PCI team. Somebody just pointed at the groin and went, "What the hell's that?" That's what it's an arterial line. You put an arterial line in. This sort of concept about, can this be done in not necessarily the most optimal place, and can it be done during the arrest, has been a question which has been put back to me a number of times about how we approach physiological management of cardiac arrest. So this is a relatively small study, but it's got some nice features. It's a single center quaternary hospital in the States. And what they do is they video all their cardiac arrests, which is quite interesting, actually. And they go back and review them. Great learning tool. Obviously, there's issues of confidentiality, but a great learning tool. 375 cardiac arrests. They attempted to put arterial lines in 82 of them. They only actually managed to achieve it in 50. So not a particularly high success rate on the initial attempts. And took them about, on average, a median of 220 seconds. They compared the ones where they put arterial lines in compared to the ones where they didn't. They got more ROSC in the ones where they got them in, 71% versus 44%. But you've got to be careful about that. It sounds good, but it may be that because you're more keen to carry on, different patient population, different level of interest in pursuing the cardiac arrest for a longer period of time, lots of confounders there. And that might be why actually it made no difference in terms of survival. So it's observational, it's interesting. All this tells me is that it can be done. And I know it can be done because we do it.
And you can find that, if you'd like to find it, it's a letter to the editor, and that was in Resuscitation. Actually, finally published on October 2025, but obviously went online earlier, hence how we managed to review it in August. But that great thing of how sites like us are able to get things out there pretty quickly as best we can. So arterial line placement in cardiac arrest. Check it out in Resuscitation. Our next post was one about the PECan abdominal trauma rule. Now, children and me are having less and less of a relationship at the moment. My children are growing up. I have one child left. I have two adults, which tells me how long I've been around doing this sort of thing. And I no longer do pediatric emergency medicine. We've very much separated off, which I think is a trend across the UK. But Simon, I know you're still very involved with pediatric emergency medicine. And I know this will be of interest to all of our listeners who do a lot of pediatric emergency medicine. PECan is obviously the Pediatric Emergency Care Applied Research Network. And this is a score that they've made up, or derived, I should say, for abdominal trauma. What do you think of this?
First thing, Iain, is that I am passionate about pediatrics being a part of emergency medicine training. I think that's really important that everybody, as they go into training, certainly maintains that element of pediatric skill. And also, the vast majority of children are actually seen either in general practice or in emergency departments. That's where they get seen. Actually, pediatrics sees fewer children than we do. So it's really core. And in big centres like mine, yes, it's been farmed out. And I work in both the pediatric emergency medicine department and in adults. Most places, it's a mixed bag. So yeah, let's keep all of those skills up. And this is a really important one because pediatric abdominal trauma, and there's been some really big legal cases recently, I'm sure you're probably aware of those, about abdominal injury being missed in children, particularly things like visceral injury, pancreatic injury, and small bowel duodenal injuries and stuff, but particularly things like handlebars. PECan, brilliant network, done loads of research. They did a score, which basically comes out as determining whether there's evidence of abdominal wall trauma or seatbelt sign, whether the GCS less than 14, whether they've got abdominal tenderness, or they've got more than one of thoracic wall trauma, complaints of abdominal pain, decreased breath sounds, and vomiting. That gives you a score. And for derivation and validation, they said that if your score was above 3, and you can do this score in MD Calc, it's the easiest way to do it. And if it's above 3, then your risk of significant intra-abdominal trauma was 4.5%. And if it was 0, there was no risk. And that's fine. But what do you do with the 1 to 2s? And so this study was going back and looking in more depth at the patients who scored 1 or 2. So maybe a bit of abdominal tenderness and a seatbelt sign, or 2 out of the thoracic wall trauma, complaints of abdominal pain, and a bit of abdominal tenderness. So relatively low level. There's often a bit of anxiety, both in the kids and the parents. Anyway, what they did is they went back and they looked at these 1 to 2s. They looked at 7,542 kids with abdominal trauma. 2,986 of those had a score of 1 or 2, which tells you there's an awful lot of kids who end up in the grey zone. And of those, so just within those 2,986 with the scores of 1 to 2, 227 of those did have an intra-abdominal injury. So that's quite significant. And of the different features that were in there, the one that was most predictive of something going wrong was the low GCS. So if the GCS is low, that although it's not going to score 3, that's probably going to push me over into more likely to do some form of imaging. And in reality, I think that's what I do anyway, to be honest. This is helpful. It's useful. People should know the score because it's, pretty good one. They should get onto MD Calc and use it there. And in this group with a 1 to 2, I think you're either going to be having to observe them for a period of time or image them. And it was quite interesting that of those 227 in that group, that's 7.6% higher than was in the original studies. But actually of those, only 48 of them had one that actually required some fairly significant intervention, like the operation or some form of procedure. So they're still a low risk group. I just don't want to miss this sort of thing in kids. It's just not a good thing to do.
Kids are tricky, aren't they? Because we worry about radiation, and we've worried about radiation for years and years. And I'm still not entirely sure I'm completely comfortable with knowing what that risk is. I just know that having CT scans is probably less good for you than not having a CT. And balancing that up is a tricky thing.
That group, I suppose, the one that's picking out that GCS 14 or less, the risk of having them requiring an acute intervention because of their abdominal injury was 5.5% in there. And I think at that level, yeah, I'm going to image that.
We're much more likely to scan now than we used to be. And I see this in my adult practice all the time. And radiologists seem to be accepting of that. Although I did the other day get asked what a patient's renal function was, but we'll skip over that just for now. But if you'd like to read that paper, it's got the rather lovely title of Tummy Aches, Tummy Tenderness and Throwing Up. Low-risk patients in the Pediatric Emergency Care Applied Research Network Abdominal Trauma Validation Study. And that's from the Annals of Emergency Medicine, and it's their journal club. Have a look. And as ever, it's great when other people do a sort of journal club review of types of things. Please do let us know if you're running a journal club. And I know that the college has started running a journal club that you can join too, the Royal College of Emergency Medicine. So keep an eye out for that. It's a great way for keeping up to date alongside all the stuff people like us are doing. We'll stick with some evidence-based medicine, Simon, and talk about more to do with cardiac arrest. And this is about intra-arrest stellate ganglion blocks. This, to me, sounds like one of those novel techniques that people would love to have, things that fix stuff. And we always like doing new things, and having a new procedure is always fun, rapport and all that sort of business. But does this actually work? Tell me a bit more about a stellate ganglion block. This is not something I've ever seen.
As you know, the stellate ganglion is formed at the point where the inferior cervical ganglion meets the first thoracic ganglion on the sympathetic trunk. I may or may not have had to look that up before I told you that. Couldn't possibly say. But essentially, the idea here is that in patients who've got VF or VT, particularly recurrent VF-VT, which we'll come on to, is that some of that's influenced by the heart being stimulated through the sympathetic nervous system. So if we block that, then maybe it's not going to be as excitable and it'll calm the hell down. So what this is basically is it's a review of studies. They've looked at 13 studies, of which there are 32 cases, wide range of patient populations, wide range of stuff. Most of these were in the hospital, typically either in the emergency department or in the ICU. And what they did is they basically had these patients in VFBT, put the block in, and then decided whether or not they got retained spontaneous circulation, whether they survived, etc. What they found in 23 cases where it was reported, they got 19 with ROSC, and 12 patients survived to hospital discharge. And mostly they were using lignocaine. Mostly they were using a landmark technique, which is interesting. About a fifth of them used ultrasound. In 4 cases, it was done without even interrupting CPR. So I think it's interesting, yes, that it doesn't seem as if it would be something which would make a lot of sense, because on the one hand, if you say we're reducing the sympathetic drive, but then we're also giving loads of adrenaline, which kind of generally stimulate the same sort of receptors I would be thinking would be having an effect, but maybe not. There is a study ongoing in Italy called the LIVE study, which is a pre-hospital RCT, I think, of using this technique in arrest. And so it'll be interesting to see that out. So at the moment, it's one of those things which I think is interesting. It's certainly not ready for prime time, but it does tell us, again, a bit like the arterial line study, it does tell us that it's technically possible. Whether or not it's something we'll see coming into practice, and whether or not it's something we can roll out to all the providers who go and access patients who are in cardiac arrest, I don't know. But I am really interested to see what happens with this LIVE study. That's going to tell us whether this is something we need to really look at.
And I will say again that I really think that we saw it a bit in the new guidance that's come out, but cardiac arrest is not one disease. And patients with VF and VT, I'm going to say it now, I would like to suggest that by the time I retire, which may be 10, perhaps 15 years time, I think the survival from VF and VT should be 100%. I don't see any reason why, with our technologies that we have and early warning systems and alert systems and everything else we have, the survival for that part of the cardiac arrest algorithm should not be much higher than it already is. We know what we need to do. We know how to identify those patients. We know that generally this should be a reversible condition. And for me, that's where a lot of our attention should be focused. Those patients who have a sudden drop because of VF or VT. We continue to bunch in all the people who are dying into our cardiac arrest management. And the 85-year-old with sepsis compared to the 25-year-old who's dropped down on a football pitch are two different people. Yet somehow they seem to be on an algorithm that's only split up by being shockable and non-shockable, which I still do not understand. But these things where we can get people out of the F and VT, get the core problem managed, are really exciting. Because, yeah, it's a bit like Kennedy saying we'll go to the moon by the end of the decade. I'm going to suggest that by the end of this next decade, nobody should be dying of VF and VT. And let's see, but I think there's a real chance. If you want to read that paper, it's in the Journal of Emergency Critical Care Medicine. And there is a link to a YouTube video on the blog post if you'd like to see how you can do a stellate ganglion block under ultrasound. But exciting things. Now, we talk a lot on the blog and podcast about moral injury and how that can affect us. And Stefan has done a really interesting blog post about how moral injury can affect emergency responders. This is actually a review of a paper from the European Journal of Psychotraumatology. It's not one I subscribe to, I must admit. But moral injury is still a real thing for us, isn't it? And how we look after ourselves and look after each other, particularly as winter is coming. It gets harder and harder to walk into departments where we can see things that we cannot positively influence and we can't make a big difference to the global bigger picture. I do find that doing little bits is helpful. But this was really talking about it on a global scale for emergency services. An interesting read.
Yeah, it really was. I like the definition, of course. Moral injury describes the impact of witnessing or being part of events that violates one's values. I think, yeah, absolutely. In currently emergency care, we often go to work trying to do the really great job, but we can't because of the circumstances we're working in, and we see harm as a result. And that's what's generating this moral injury type of thing. So what these investigators sought to do was to think about how it's conceptualized amongst emergency responders in the UK and how they were experiencing moral injury and what was driving it. They used something called Q methodology. It's a mixed methods I don't understand particularly well, but essentially they had 7 experts who created 45 questions. And then they went out to police, fire, emergency medicine, ambulance, community first response staff and did them to sort the statements depending on how much they identified with them. And from that, they could draw some conclusions about what it is that's affecting people. And there's a few things actually. They're just able to categorize them into factors which are a loss of trust in other people, a loss of trust in themselves, interestingly, and then also a loss of trust in authority. How would that work out? The first one being trying to help while feeling hated, misunderstood, and undervalued. I'm sure many people listening to this will have had poor experiences, but no fault of their own when people have been pretty horrible to them. And that creates disconnection and particular loss of trust with the patients, which are, and that's a difficult one, isn't it? We're trying to help and then it's being thrown back at you. Not all the time, but sometimes. Facts 2, getting eaten away by the job, just hard work. Anybody who's using an electronic patient record, maybe just me because I hate it, they don't necessarily feel numb or disconnected. Instead, they just feel like eaten up about whether they're managing to do their best. And then the last one, it's all on the personal responsibility and personal protection. They get suspicious, maybe a little bit paranoid, angry about having to choose and their personal well-being versus their job and what they're trying to do, all of those kind of things. The conclusion that Stefan's brought out, which I think is quite interesting, is that this idea of moral injury isn't a one-size-fits-all at all, and that various different factors may cause it in people. And actually, as you progress through your career at different stages of your career, different stages of your life, it may be different elements of those 3 big factors which are putting you along that route. And I think that's important because if we can understand this a little bit better, and if we see these issues occurring in ourselves or in our colleagues, if we understand it better, then maybe you've got a half decent chance of improving things. So yeah, it's a really interesting read on a very important subject. But it's definitely one to go away and have a read on your own. There's a lot of really interesting quotes and information in there. I enjoyed it. I enjoyed the read, and for all the wrong reasons, sort of thing.
And it is a time to remind ourselves to just be kind to each other and be kind to yourselves. The next few months will feel disheartening. The UK, we are in the face of another junior doctor strike. There's clearly a huge amount of unhappiness in amongst the NHS workforce at the moment. Morale is incredibly low for multiple reasons that are far too complex to go into here. But just be kind to yourselves and be kind to others. And I do find the small little gestures are the things that make a difference to me. On a shift, taking an elderly patient an extra blanket, or getting somebody a cup of tea, or offering them a glass of water, I find can be just as satisfying as doing a really amazing resuscitation. And also the same for colleagues. So just being supportive, which I'm in a privileged position to do as a senior doctor, making sure that people are having a good time, making sure that they've got support for making decisions, making them feel empowered to make decisions. There's all sorts of things we can try and do, and the little bits do make a difference. So don't lose heart, don't give up, keep going. Actually, Stefan did another post in August, which is a little bit about not losing heart and where we could go in the next 10 years with some foresight and using technology and being brave, and about where emergency medicine could be by 2038. For me, it feels a little bit hopeless at times at the moment. I don't know quite why it's so intangibly unfixed, but it does feel that. But Stefan has written a post here imagining he was writing it in 2038 when he was a few years older. And he does have a huge amount of experience already from working in different healthcare environments, including in South Africa. But actually, he presents a sort of positive spin on where we could be if we act appropriately now, and we're brave, and we make some good decisions. I don't know, Simon, do you feel optimistic about the next 10 years?
I'm naturally optimistic, which is possibly a personality flaw. I'm not massively optimistic that things are going to suddenly change, but I do think we have the tools and the people who can do it. I think there's a great quote in here that said, the early 2026, Stefan imagines that the college president stands up and says, we have 2 choices. We can manage decline gracefully, or we can demand the resources to build the emergency medicine system this country deserves. There is no middle ground. And it feels a bit like that. It feels like we do definitely need to get a grip what emergency medicine is. There is, from the college point of view, there is now a document that actually defines what emergency medicine is. It's called the GPEMS document. And every emergency physician in the country should be looking at that. There's a whole bunch of stuff that comes out of it. Emergency medicine isn't practiced the same in every department across the country, but we need to calibrate it so that it is. I think if you go to an ENT doctor in most hospitals, apart from the sort of really weird tertiary, quaternary stuff, ENT is ENT. It's not like that for a lot of specialties like gastroenterology and stuff. I think emergency medicine departments, they behave very differently. And I think there is some work to redefine what is our core business, what is important to us, what we do really well. Stop farming stuff off to other people, which actually is our core business, and don't get left with stuff which other people don't want to do. That's probably enough politics for now. So the stuff is out there. We have the tools, we have the availability. We will need support from politicians and from the NHS. The NHS 10-year plan, it may have opportunities for us. If we come together as a college, as a group of emergency physicians, then I do think we have a really good future. The patients will still be there. We will still be there, but we need to make it workable and good. And we can do great things. The really good stuff in here from Stefan is go and have a look how things might be different. And then we can think about how we can get there.
The one word I always come back to when I'm thinking about these things is bravery. We need to be brave in what we're doing. We need to be brave in defining who we are. And I think the college does that very well. But we need politicians to be brave as well, to see that the simple solutions or quick fixes or depending on technology that seem to be an obsession at the moment are not necessarily the way that we're going to make this better. Actually, what we need to do is be brave and trust people. And I did write an article for the BMJ Opinion recently, which was about us making clinical decisions and having clinical courage and not always depending on technology. And I agree with you. There's certain things that in emergency medicine we're really good at, but we seem to be asking other people to look after, mainly because it moves them out of the environment where they're subject to a target. And I'm mindful of all the good stuff the 4-hour target has brought us, not least probably my job in 2008, because I think without it, we wouldn't have had consultant expansion. But it does also mean a pressure to move people to other areas in a hospital, maybe not for their benefit, but for a numerical benefit. So there's lots of challenges, but bravery is where we need to be. I'm just not entirely sure the political structure at the moment outside of places like the college is ready for bravery because it's too scared of other things that may be on the horizon. But read Stefan's post. It gives you hope. It gives you optimism, particularly if it's the start of an emergency medicine career and you're wondering quite where it's going to take you. Have a read because it could and should be in quite an exciting place in the next 10 years. And hopefully there's a legacy that people like Simon and I and others can leave that will make that achievable. Simon, let's move on to September. Some more evidence-based medicine. We're covering a lot this month to try and get 2 months covered in our podcast. Hydrofluoric acid burns. Greg Yates, who keeps giving us great toxicology type posts. And if you're into toxicology or you just need to know more about it, which I think we all probably do, then do keep an eye out for these blog posts. I think this is the 8th one that he's done. And this is about how you treat hydrofluoric acid burns. This is one of those things I've learned for exams. I don't think I've ever had to treat, maybe once a decade ago, but it's worth having in your mind. And this is about which one we should be using.
Yeah, so I've seen a few. I think do they use it for cleaning stone buildings and stuff, I think is where the last one I saw. Anyway, pretty nasty stuff. Hydrofluoric acid, what it does is it gets into the soft tissues and it just keeps going and going. So you have to stop it. And the treatment for a long period of time has been to use calcium gluconate gel. It's quite expensive. It's in the list of arcane antidotes that we need to keep in the department. Amazingly, in the US, because there's a US study, and people actually just make their own up. So they get calcium gluconate, then get some gel, like acrosonic gel that we use on the ultrasound machine, and mix it up and then use that. So it's like a homemade brew. And essentially what they've done in this study is tested that. Does it work? Can you make your own up? And is that effective? So what they've done is they've basically shown that no. And just use the commercial ones. If you try and mix it up on the day, by taking calcium gluconate out of the syringe and mixing it up with some gel and then smearing it into whatever injury the patient's had, it's nuts. Don't try and save money. Use the proper stuff. Actually, in terms of effectiveness, they didn't actually test that. They didn't use patients. They just looked at the characteristics of it. But it came out the wrong concentration, the wrong sort of consistency, and just don't do it, basically.
So if somebody comes to you with a great cost improvement plan, and this is one way they're going to save a bit of money instead of storing the actual commercially made stuff in their cupboard, you can point them to this paper in the Journal of Clinical Toxicology published in June this year. And it is true, you get what you pay for in most cases. Probably that's the same for emergency medicine, isn't it? An emergency department.
Yeah, the other thing about this one is it's that little bit of a caution to, we see a lot of stuff on social media, don't we, about, oh, the trick of the trade is I'll do this and I'll do that. Sometimes by very enthusiastic and plausible people. Just be a little bit careful when you see a trick of the trade. Go and ask them, where's your evidence? Does it work? Show me the numbers.
So the next article is another journal club post about ketamine or midazolam as the first choice for pediatric status epilepticus. This is one of those conditions that is incredibly scary. If you have a child fitting in front of you and it's not stopping despite your normal efforts, then it can become one of those times where you start to get anxious. And knowing which drug to use is important, and knowing which evidence backs that up is also important. Sam, you wrote this blog post. Tell us a bit more about it.
Yeah, I think I picked this up from Skeptic's Guide to Emergency Medicine, great blog post with Ken Mill, and they reviewed this paper. I'm interested because status epilepticus is something we see both in the pediatric emergency department and pre-hospitally. And you're right, it can be tricky to deal with. And ultimately, we might end up putting these people to sleep. And there's always been a bit of a debate about whether or not we give thiopentone or whether we give ketamine. Can ketamine make it worse? Which is the reason why I got interested in this. The study itself is an RCT of 144 children in Egypt. And what they did is they either gave them ketamine plus midazolam or just midazolam alone for those patients who were in status. And essentially what they found is the kids who got the midaz stopped in 76% of cases. If they just gave midazolam alone, it's 21% of patients. You think those are very low rates of stopping, but actually these patients were the ones who'd been brought to the ED. The average time it took them to get to the ED was 34 minutes. So by 34 minutes, if you've been fitting for 34 minutes, that's quite an abnormal bit, isn't it? Let's face it. The study is reasonably well conducted, although it's single center, it's not necessarily our population of patients, but it does suggest that there's a benefit to CAT with midazolam versus midazolam. However, it's not really what happens in the UK. So I'm finding it a little bit difficult to bring it to us. So the patients that we have who are known epileptics often have rescue medication given to the families, and it's often being given before the paramedics have arrived. And then when the paramedics arrive, then they will potentially give other benzodiazepines to try and stop the fit. So by the time they arrive in my emergency department, they've often had 2 doses of prior benzodiazepines given by paramedics or family. So what it tells me is ketamine is probably fine in fitting kids, so I don't mind popping off to sleep with that if I need to do so. Although it's not been tested here, but it's probably okay. But also that I think quite grateful for the incredible work that our paramedics do in the UK, and also the great epilepsy services that supply, teach, and support families who give the benzodiazepines for fitting kids, because I think this might be a different group of patients.
So if you want to read that paper, you can find it in Pediatric Neurology from June this year. The title is Combined Ketamine and Midazolam versus Midazolam Alone for Initial Treatment of Pediatric Generalized Convulsion Status Epilepticus, the KET-MID study. And as Simon mentioned, Ken over at the SGEM has done a great review of this. One of his recent episodes called Seize the Day. I love how Ken manages to get some form of musical title into all of his podcasts. And do have a listen. And it's one of those great times where actually multiple different people, multiple different podcasts doing a similar topic, it's worth having a listen to all of them. Don't ever believe one of us. And certainly always go back and read the paper for yourself. We can't emphasize that enough. A topic close to both our hearts, as we said already, Simon, is the treatment of out-of-hospital cardiac arrest and the management thereof and how we can expedite what we're doing. And when we were at Zermatt this year for the Big Sick, Brian Burns was chatting a bit about this. And as part of this next paper, we're going to talk about the evidence trial. This is about whether we should move patients with a refractory out-of-hospital cardiac arrest to hospital and expedite that transfer, which has always been something really interesting to me. I always thought it'd be better to be in a place with bright lights and ability to do stuff if we can get a patient there safely, as opposed to waiting by the roadside or wherever you might be, trying to get a return of spontaneous circulation before you move. Simon, what do you think of this? I know it's a subject you think about often.
I think there's no point in taking a patient to hospital unless you can do something different at the hospital. So if you've got a service where you can deliver essentially the same ALS in the emergency department as you can with the paramedics at the roadside, then there's probably not a lot of point in moving, assuming you've got enough people and the kit. But if you can move to something which is different, then that argument doesn't really hold true. And so what they did in this trial in New South Wales, Australia, is they made a decision about whether or not they were going to stay on scene and continue the ALS for VFVT patients who'd had 3 shots, so the refractory VF, whether they were going to hospital, and specifically to go for either to hospitals which had PCI availability, potentially intra-PCI, or ECMO centres, of which there are more ECMO centres, I think, in New South Wales than there are in the entirety of the UK, which is quite frankly nuts, but there you go. So there's quite a lot of work around ECPR, putting on ECMO in an emergency, but lots of different models of doing it. And in fact, in Birchester and my neck of the woods, we did try and do something similar to the evidence trial, which is to take patients from the roadside to the hospital and start ECMO on them in the hospital. But that didn't work. We just couldn't get them there in time. So what they did in this study, it is in the Lancet Respiratory Medicine, and so pretty high impact journal. They took patients aged 18 to 70 with a witness cardiac arrest of presumed medical cause. They had to have bystander CPR and initial shockable, and then after 15 minutes of life support or 3 rounds of professional resuscitation, then that was the point where they made the decision to randomly allocate them to either stay or take them to a hospital which could do things. And there were 15 receiving hospitals with a degree of variability about what they could do in those hospitals. But essentially it was angiography, PCI, or ECPR, i.e. putting them on ECMO, or both. And yeah, they just compared the two really. Quite nicely, they looked at their outcomes were looking at cerebral performance category, so neurological outcomes at hospital discharge, and then a nice design trial, good people running it, and excellent stuff. So 206 patients, they had to take a few hours. They ended up with 197 analysed. And cut to the chase, what did they find? Amazingly, it did make a lot of difference. So the success rate at hospital discharge, I think, was 15% versus 16% for CPC category 1 and 2, so doing really well neurologically, 19% survival overall in both groups. And you think, well, okay, that's a negative trial. It doesn't really tell us what works. And that's true. So this system does not seem to offer any advantage. That's what this trial tells us. But there were lots of problems as they went along. They had difficulty with the power. It is underpowered to show any particular big treatment effect. There were lots of delays to hospital therapies. It took them on average, I think the median time to get to hospital in the experimental group was 55 minutes, and they weren't starting ECMO till 80 minutes. And there's lots of other studies that show that's just too long. I think there's reading one recently that said about you need to get these patients on pump within 45 minutes if you're going to see significant benefits. Many of the standard patients that were supposed to stay were transported anyway, and often the ECPR was not available. So you randomize these patients, go to the hospital where they got ECMO, and ECMO wasn't available. So it's a good trial, but it seems to it's not really told me what the answer is here, apart from the fact that it's still my belief that if we're going to do things like ECPR, because of the time issue, we have to take the ECPR to the patient, not the patient to the ECPR. There's no evidence for that here. It doesn't tell me for sure, but I think that's what it's telling.
This is that group that I was talking about earlier, isn't it? Where I think we can improve our survival rates. And I'm so pleased that people like Brian, and this is a big cohort of the New South Wales Medical Emergency Medicine Fraternity, have looked at this. The list of authors is some very familiar names. And it's great to see this stuff is being thought about. And it's one of the exciting things where in emergency medicine, we really can make a difference. There's a lot we can do. We've talked about dual sequence defibrillation, all the different types of things, stellate ganglion box we've mentioned today. There's a lot to do for this group of patients. And so I really think there's somewhere we can go that may mean we can improve survival from this otherwise devastating occurrence. And often this is young, previously fit people who are dropping dead. And if we can save those people, that's why I got into emergency medicine. One post that we haven't mentioned, Simon, I just want to get for listeners to have a look at is the Geckos Global Health and Emergency Care Research Summit that Anita wrote. This is a very comprehensive post, and I don't think you and I can particularly do it justice. There's a lot on there. There's a lot of content. And this is a group, of course, that Anita was part of forming some years ago. And it's worth having a look at. It gets us to look outside our own little environments to a more global picture and some of the stuff that RChem is doing outside of the UK.
I think from an emergency medicine perspective, but also just from a world perspective, we look around today and we've got significant conflict in many areas across the world, which we might think we're isolated from here. We're not. There's significant issues around climate change, and all of these factors could well have an impact, but also we have the moral, ethical responsibility to understand what's going on and potentially support measures that make things better. So yeah, it's a really comprehensive post. List of speakers on that Geckos conference was amazing. And there will be more of those next year, and he's just planning. When they're coming up, we'll try and let people know because they're very high quality.
That, Simon, is that for August and September. We've crammed a lot in. This is partly because you and I seem to be so busy that doing this on a monthly basis is much harder than it once was. I know you're incredibly busy with your work at the college and other stuff. You still always remind me of Hermione in Harry Potter. You must have a time turn and somehow live twice. There's no other way I can explain how you get to do what you do. So very grateful we've managed to get some recording done today. And please do keep reading the St Emlyn's blog and listening to the podcast. More episodes coming from us from the Basics Conference and lots more to come in the future. And please, as winter comes and things get tough, do take care of yourselves and each other.